Yep, we're good. All right. Good morning. My name is Brianna Yoakum. I'm the Director of Accreditation and Professional Development with the Washington Alliance for Quality Recovery Residences. We're really glad that you're here today for our webinar, Responding to Mental Health Crisis. Like I said, it looks like we have a smaller group today, but that is okay. We're just so glad that you're here. This is such an important topic when working in recovery housing. And we're just grateful that you came to spend your morning with us today. I'm excited to share that our presenter is someone you might recognize. His name's Cameron Fordmeyer. Cameron has presented for us before, and he brings extensive experience and practical insight into supporting individuals during crisis in a safe, trauma-informed way. Cameron, we're so grateful to have you back with us. Just a few quick housekeeping notes. Feel free to drop questions in the chat at any time. We'll make sure Cameron has time to address them as we go and towards the end. The recording, slide deck, and any resources mentioned today will be sent and made available to everyone who's on today. With that, Cameron, I will hand it over to you.
All right, good morning, everyone. So I'm a little under the weather, so if my voice starts to crack, I apologize. I might have to drink, but I'll try my best not to cough or sneeze or anything else that comes with that. So,
Oh, well, thank you for being here.
yeah, of course. So we'll go ahead and get started with some introduction piece. So thank you, Brianna, for introducing. My career started in 2001, right out of high school in community protection group homes. And so I've done a majority of my career has been in high intense, high acute environments working with people in crisis. And so started off again in group homes, and that was community protection homes. So individuals who had been committed a high level crime like arson. We did have some people in there for murder, all different types of crimes to where they couldn't go to Eastern State Hospital because they had been found incompetent to stand trial. If they send them to Eastern State, they may take advantage of people. If you send them to prison, they may take advantage of. So I cut my teeth in that right off the get-go as an 18-year-old dumb kid in those homes. And then I progressed on to psychiatric inpatient units and crisis triage facilities. During that direct care time, I did some case management, some crisis counseling, and in 2010, I became a designated crisis responder, which I still hold that designation today, despite not working for one of the crisis providers in our region. So about in 2012, I switched over to a leadership role where I started managing a number of services. So I have managed crisis services for Benton and Franklin County, the prosecutor diversion program, which is the complement to mental health court, so that those individuals who have been found incompetent or competency has been raised. I was also the manager for our True Blood Phase 3 program, which paired up designated crisis responders with law enforcement, and they rode co-response in that. Also for jail mental health for Benton County, and currently one of my roles is I'm the regional administrator for the Recovery Navigator program and assisted outpatient treatment with Greater Columbia Behavioral Health. At the night time, because I don't have enough to do, I am an adjunct instructor in the psychology department and the SUD department for Columbia Basin College. So that is who I am and why I'm speaking. My hair's a little bit longer now, but that photo, so stuff has changed. All right, so guidelines. When we talk about this in these trainings, there are some limitations. And part of that is that we don't want you diagnosing people right off the get-go. You may get some good information, but that's not the time to go back and diagnose all your family members at Thanksgiving or Christmas now, because you had a whole training on mania, psychosis, depression, and anxiety. So limitations, this doesn't qualify us to do some diagnosis, and please don't do any self-diagnosing too. It happens all the time with my cohort in class when we start going through these diagnoses, and then people start saying, I have that, I have this. So please no self-diagnosis or diagnosing of others. The other issue for any group work or any webinar is confidentiality. So if you have any questions, you can always send those to me in the chat. I will not put those on here, and I will address them as a general. I won't bring up any names. So if you have that, but also if you're on camera and ask a question, please don't disclose something that you wouldn't want either recorded or somebody in the webinar to view or see. Also, we're going to try our best to follow the rules and guidelines of your employer. So if anything we discuss here is contradictory or is not quite within your guidelines of either your RCW that you follow or your agency's policies and procedures, always stick to those first and check with your supervisor if anything that we discuss is not 100% on bar. Also, we use our best to use people first language. So when we describe diagnosis, we are going to describe them as people living with these diagnoses first, the schizophrenics or bipolars or derogatory terms like druggies. So we're going to refer to people as them first and living with these issues. The other thing that I like to do is try to be or have acronym police. So if I start talking about he was diagnosed with ODD, referred to PDP, high on PCP, and who's down with OPP, yeah, you know me. But that somebody is saying, what are you talking about? So clarify those acronyms. We'll try not to use too many of those. And if I do, I'll remember to at least say what that acronym stands for. The last little bit of that is parking lot. So if there is a question that's presented or somebody comes on camera and asks a question, if it pertains later on in the slide deck, I'll parking lot that one, just let them know that it's coming up. Or if it requires additional services or resources, we'll wait till after the webinar to discuss that individually. All right, so today we're here to talk about mental health crisis, and a part of that is also discussing and having a better knowledge of what the Involuntary Treatment Act is. And so when somebody says ITA, that's what that stands for, is the Involuntary Treatment Act, and it is civil law under RCW. And that is what a designated crisis responder can do to detain somebody against their will for an initial detention. So we'll go over that. I think it's very important to have a better understanding of that, not just so you can know the limitations of what we can do, but also so that you can help better phrase or better discuss your concerns with a designated crisis responder if you are trying to get somebody involuntary detained or they need that for their own safety or the safety of others. The other thing we're going to do today is become more familiar with various signs, symptoms, and those warning signs of any self-harm, SI, which is suicidal ideation, HI, homicidal ideation, as well as mania and psychosis. Those all play into crisis and also play into the Involuntary Treatment Act. We'll also get some of the substance use in with that and talk about some of the changes that were made to law in 2018. We also want to develop a better understanding of how to assist those experiencing mental health crisis. If you have had no experience with that, it gets kind of scary when you're the first line of defense and you're trying to manage those. So we'll get a better understanding of how to talk to people, how to phrase questions, how to assist somebody immediately. And then hopefully during that process, you'll gain a little bit more confidence and empower yourself to at least be able to do those first steps to make sure that our population is taken care of. All right, so some of the terms that we're going to use too in here, I want to clarify. So when we talk about polysubstance use, that is where we're using more than one substance. So it could be alcohol and illicit drugs. It could be that we're using them together. So we smoke weed and we drink alcohol together, or it could be to come up, come down. So I drink and then I use a stimulant to come up and then I use a depressant to come down. So they don't have to be used together, but they frequently are, or they can be used separately for separate desired effects. So we use polysubstance use. That's what we're talking about. The other thing that we will discuss is comorbidity. And so these are individuals diagnosed with either two or more, so they can be multiples. If you've ever seen somebody's diagnosis, usually there's a bunch of them on there, and that's for a reason, and we'll talk a little bit about that coming up. But as far as the definition goes, those are independent disorders occurring at the same time or near the same time. And so keyword was independent. So for example, most people who have been diagnosed with depression also are diagnosed with anxiety disorder. They tend to go together, but they are separate diagnoses. The problem with disorders too, especially when they're untreated or they've gone untreated for a while, is they typically breed other disorders. So if you have one disorder, that typically leads to another disorder. So for example, did I start feeling so down, so my energy level is not there, I'm missing work, and now started to get really restless and anxious about that. And now I have anxiety, or was it because my anxiety disorder is too much that I can't come to work, and now I'm leading into more depressive symptoms. And then I start medicating on top of that and self-medicating with alcohol and drugs. And then it kind of steamrolls so on and so on to multiple disorders, and maybe they're which gets us into the co-occurring category, which is two or more disorders, but typically they are mental health disorders and substance use disorders. And they are to the level to where we don't have sufficient evidence to rule one out or the other. Is it the chicken or the egg, or is it I self-medicated with alcohol because I'm depressed, but if I felt better, I wouldn't use alcohol? Or is it that I have both a alcohol dependence and abuse disorder and I have a depressive disorder? So it can complicate treatment, especially for what we're talking about here is how to help with mental health crisis if they are using two or more substances and they have mental health diagnosis on top of that. It can either one complicate treatment on, and it can also complicate the diagnosis piece. Which one do they have? And it may depend on where we send them. If we send them to a detox facility, they're probably going to be tackling the substance abuse issues first, not the mental health. If we send them to a psychiatric inpatient unit, they may be dealing primarily with the stabilization of those mental health issues and not addressing as much as they should for the substance use disorders. So we're going to use these terms in and out, but I just wanted to make sure that we all knew and understood what those terms were before we go on. Okay, so now everybody's favorite, the Involuntary Treatment Act. If you have ever worked with clients at one time, you have probably experienced a crisis issue and you have probably called somebody for help in that. So when we talk about the Involuntary Treatment Act, it is a revised code of Washington, and that's what the RCW stands for. And for adults, that's in 7105, and for adolescents, so 13 and up to 17, is 71.34 for youth and adolescents. And I said 13 not because it doesn't apply to the other ones, but that is, and we'll talk about some of the limitations, that is the age that detentions affect. If they are under the age of 13, they cannot be detained under the Involuntary Treatment Act. You can do family initiated treatment, and so we'll talk a little bit about that too. But so recent changes to ITA law. Substance use disorders prior to April 2018 were not included in the Involuntary Treatment Act. For anybody who's been working in the last few fields, that seems silly, and it always has been silly that those were never. But back when I first started in crisis work, you would have to make a case to where this person who is suicidal, are they suicidal because they are depressed, or are they suicidal because they're drunk? And if they were drunk, we could not detain that person because it was potentially due to the substance use disorder. That has now changed. So you can do ITA Involuntary Act detentions on people for both substance use disorders and mental health. So that changed in 2018. The other thing that happened too is gun rights are lost at initial detention as of January 2021. So if you are detained, those initial gun rights are lost, and you can petition to get them back, especially if it's for danger to self or danger to others. Sometimes there's some caveat in there on reasons why, if it was non-violent or it was grave disability, but there weren't any issues that you were trying to hurt others or had thoughts about hurting others or yourself, there may be some wiggle room in that, but those initials are done. The other thing that happened in January of 2021 is detentions changed the hours. So prior to that, and I still hear people talk about them, so they're going to be gone for 3 days. 72 hours was the prior one, so 3 full days. It has changed now to 120 hours as initial detention, so 5 days. Keep in mind, this does not count weekends or holidays, so they are business hours. So they are the type that the court is open for. So if you detain somebody and it's Thanksgiving and they consider Friday a holiday too, their time doesn't start because they go Saturday, Sunday. They don't start until Monday. So those can affect length of initial detention because those are just going to be business days hours. And then another piece in there. So in Washington State, only a designated crisis responder can perform an ITA investigation. So an involuntary detainment of a person that gets their will to a secure detox facility or a psychiatric inpatient unit. Some, those of you heard swim facilities, evaluation and treatment facilities, CTFs, some CTFs can take detentions, crisis triage facilities, but a DCR is the only one that can perform that evaluation and send somebody to those facilities. All right, so a little bit more on the act. Even though a DCR is the only one that can perform that evaluation, anyone can make an ITA request. There is some miss in there that it has to come from a doctor or emergency department. It has to come from a fire or EMS. It has to come from a judge. anybody can request an involuntary treatment evaluation. So to do that, you could call your 988, or if you're in a region that has a local crisis number that you have in addition to 988, you can always call and request that. And it was also another myth that you have to take somebody to a emergency department for them to get help. Most crisis response teams are mobile now, and the expectation is they go to where that crisis is. So evaluation can take place anywhere in the community, but the issue is if privacy or staffing of your agency, it's a secured spot, anywhere like that may be the issue on why they cannot do the evaluation in that location. So most emergency departments, stuff like that, most people have in-house individuals that they could do, so you could send them to the place where the designated crisis responders work, etc. There is another myth that you'll hear. So medical clearance is not required to be evaluated, but it can be a requirement for placement. So for a swim facility, for example, a secure withdrawal management inpatient for substance use, they may want that, and they may request that before they accept somebody. But that is not a requirement for somebody to get evaluated. So if somebody's saying, well, we need them to be medically cleared first, sometimes you can do a medical clearance at the facility you're sending them to, or it's not needed. And to be honest, it's blood and urine. So it's nothing that they couldn't obtain after the fact. So if somebody is telling you that medical clearance is required first and we need to take them to the emergency department, there is a huge push to eliminate unnecessary emergency room visits, as well as unnecessary police, fire, and EMS, if we can handle that on our own and get the person evaluated prior to medical clearance. One of the reasons why we have that is when I look, at least for our region in Greater Columbia's, only 20%, and it's never risen above that, result in a detention. So you're talking about 80% of all evaluations don't result in a detention. So why are we doing 100% medical clearance on everybody? Right. So more reason to get people evaluated where they're at and where the crisis is occurring. The other thing that happens with that is if you don't do it in the place that the crisis is occurring, the evaluator loses a lot of information. They don't see the same thing that the requester is seeing. They don't, there's some sobering effect from moving from the place that the crisis occurred to an emergency department. And you're with a bunch of doctors and you're in an emergency department. There's nurses, there's needles, there's all this stuff. Maybe I get something to eat. The whole time passes. It takes 2 hours for the designated crisis responder to get there. I may have a completely different presentation by the time that the DCR could have seen the evaluation in there too. So there is a lot more value other than just we want to get to the person as soon as possible to see them where the actual issue is occurring. The other thing that's happened is we made some changes to the law where those of you who have heard Ricky's law, that issue kind of got fixed with the addition of substance use disorders. But the other piece of that is Joel's law. And so if you perform a ITA evaluation and for whatever reason this person does not get detained, back in the day, that was it. You could only request another evaluation. Now, Joel's law gives the family, friends, providers, legal guardians, anybody who's involved in that care a second chance for an appeal. So what you would do is there's two ways that can be. One is if I request as a community member or a housing provider or a family, whoever, and that evaluation does not get done, and it does not get done within 48 hours, I can then request a Joel's law. Now, that's not at fault of the DCR. Maybe they're MIA, maybe they're boarded up in their hotel, maybe they're in their house and they refuse to go via crisis, they refuse to go via law enforcement, fire, and EMS. They just cannot do the evaluation. In that case, you can still do a Joel's law. The most frequent way that they do Joel's law is if a designated crisis responder has evaluated, decided not to detain, or they didn't meet detention criteria, then the family, friend, whoever the requester is, can petition the court for the judge to make the determination. So they would fill out a Fact 2 form as the official wording of that, but it's pretty much in layman's terms a witness statement. So you would fill that out. You would fill it out in first person because you can't do it in third person. So you can't say my cousin said, the staff said this. It has to be what that person witnessed themselves, and it would involve specifically towards that detention criteria. So then a judge will get that, read it, they will request the DCR's paperwork, and they will view both of those and make an independent decision on whether the person should be detained or not. So more on here. IT evaluations are very lengthy, at least when it comes to paperwork and the things that they have to do. And so I think it's worth noting because this helps when you're talking to a crisis responder on what they're looking for and what their evaluation typically consists of. So usually there's some form of a mental status exam or a mini mental status exam. So they want to know the person's mood. Are they angry? Are they depressed? Are they inappropriately laughing at stuff that doesn't make sense? What's their mood like? And is their affect matching that? Are they having any specific hallucinations, command hallucinations, making them feel like they are obligated to do something against their will? Or are they having delusional? What's their thought process like that? As well as rate and rhythm of speech, volume and tone, grooming, hygiene, appearance, those type of things are considered in the evaluation. The one that is most common that people understand is suicide. But under ITA, is that suicide current or was it 3 months ago and it hasn't happened again or they haven't requested? So is it current or are they current thoughts? And then taking that further, rather than just suicidal ideation, do they have a specific plan and intent to go through that plan? The other thing they look at is means and history. Have they attempted before, and do they have means to go through it this time? And or have they been collecting means for a while? Maybe they've been cheeking meds for a long time, filling prescriptions that haven't been used. They're gathering sharps, firearms with ammunition, etc. So do they have means and intent to use through that? The other thing in that is self-mutilation, and we'll talk about the difference between self-harm versus SI and where that line is at with self-mutilation. Homicidal ideation is similar, but you may have a criminal element in that. So if somebody is threatening imminent danger issues to others, that is going to be probably a straight up 911 versus a 988 call. But homicidal ideation also plays into this current 7105, 7134 ITA law. So keep that in mind, but the criteria is the same as suicidal ideation. The other piece to that third category, which is hard for people to understand, especially for people who are still working in the field, is grave disability. So the best way I can explain grave disability in layman's terms is if I am on the roof to jump off and hurt myself, that is suicidal ideation. If I'm up on the roof to prove to you that I can fly, that's grave disability. So I'm putting myself and others at danger due to my mental health symptoms or my substance abuse issues. So if you are doing things that would be directly a resultant of your drug use, mania, psychosis, states of depression, and it is directly resulted in that, that could lead to you hurting yourself or others, then we've had people run through canyons naked. Well, if you run up on the wrong family and they're walking their family through the canyon and you're naked running from aliens that are trying to put stuff in you may get drawn down on. You may get hurt. Somebody may assault you. Same thing with knocking on people's doors for safety. So it doesn't mean that they have to try to hurt themselves. It could be that their mental state or their current substance use is putting them directly in danger of other people hurting them or them hurting themselves too. So moving on, death by PowerPoint, you can go into all of these, but this is also what goes into an ITA evaluation. So do they have a diagnosis or a history of those diagnoses? What is their medication compliance? Are they prescribed meds and not taking those? When people say, well, they want to go, are they a good faith volunteer patient or a good faith historian? Meaning, can they actually agree and understand the terms of what they're agreeing to at a psych hospital or at a swim facility? Do they understand the ramifications of going in and the legal ramifications? Maybe they're a hunter and they don't want to lose their firearm. So you can say, well, they want to go. Well, are they under the understanding of what that truly means to go or potentially have consequences attached to that? So the other thing that we talk about too is volitional control. That is a nice word of saying, are they malingering and are they making it up? Or is this something that involves involuntary hallucinations? Or are they turning the hallucinations on and off and when it's convenient for them? So you see that historically in the jail when I worked there a lot is people would say they're suicidal to get out of the general population. Then they would go into protective custody and then they're no longer suicidal. That means that they have volitional control. They can turn it on and off. If you were truly suicidal and need to be detained, it wouldn't matter where I put you within the jail. It wouldn't matter whether I take you from the jail to the psych hospital. You would most likely still want to die by suicide. So volitional control is a fancy word, like I said, for malingering. Can they turn it on and off, or is it going to be there regardless? And we'll get into a little bit more of the diagnosis stuff with psychosis because it does ebb and flow, but it's not like I can pull it together when it's convenient and otherwise when it's not. It is pretty out of control with auditory and visual hallucinations. So we'll talk more about that to come. So there are some limitations of the Involuntary Treatment Act, and this is important for people to know as well. So ITA is a civil law. It is not criminal. So when we talk about civil law, that is where you're going to run into issues with trying to get police involvement. If this is 100% something that you're calling a police officer for and there's no criminal element of it, the amount of stuff they can do for a civil law is limited. So if you have a great understanding or working relationship with your police officers and they're under the pretense that they can put people in protective custody, and transport them, fantastic. But some police and law enforcement agencies or entities are not willing to do that as much. So there's a thing called a custody authorization, and that gives fire, EMS, law enforcement permission at least to transport somebody from point A to point B. So from a recovery residence to the ED, from the ED to a psychiatric inpatient unit. But a lot of people say that that is civil, that doesn't protect them, they're not going to do that. So you may get into some debates, some understanding depending on where you're at and what the law enforcement's climate is for helping with that, because again, it is civil law and not criminal. So the other thing of ITA is that designated crisis responders are tasked with looking at any and all least restrictive alternatives. And so before I can detain somebody, I have to say that there are no better least restrictive alternatives for this person. And what that means is anything other than detention is a least restrictive alternative. So if there is a family member who is willing to keep them safe and they can be safe and we can lock up medication, we can lock up sharps, we can remove firearms and they have their appointment the next day with their provider, that may be something that you go with because that is the least restrictive alternative available. So if there is nobody that can help them with a safety plan, if there's no means to keep them safe, and the person is not willing, then there is no least restrictive alternative available. So a DCR has to prove that there is no least restrictive alternative available. The other caveat to that is that the least restrictive alternative is appropriate. So for example, we've done evaluations on people who the significant other is saying, hey, I can keep them safe. But when you do a little bit more collateral information, this person's also been charged with domestic violence on their partner. And there's some other issues in there. So would we send that person home who has potentially maybe not the best fit to keep this person safe? That may not be appropriate. So the other caveat is it available? And if it is available, is it appropriate to situation? The other thing is when DCRs get a bad rap, and that is a rough job, they do get a bad rap. It's either a patient that's upset with them, it's either a family member, it's either the facility that they got sent to, law enforcement, name it. The problem with doing a detention is there has to be a facility willing to accept that person first. Otherwise, the person's not going to be detained. So if no facility is willing to accept them, they don't have a legal way of detaining them. There's some other stuff in some communities that you may have, like for example, there's a single bed cert that they can do, which means that if I'm evaluating them at the hospital, I can detain them to that hospital before they go to a psych hospital. But that's only if that emergency department and that hospital that's attached to is willing to do single bed certs. And most are not because of the requirement of they have to perform the same amount of services that they would receive at that accepting facility. And it's not likely that most EDs have a psychiatrist, 24/7 med management, have the ability to do seclusion and restraint, all the things that a psychiatric inpatient or swim facility could do. So most emergency departments don't do that. The other thing is that when you're dealing with a private facility, the private facility can decline people for whatever reason they want to. They can decline them for legitimate reasons, like that this person is aggressive and has a history of violence, or they can decline because the person is medically compromised with diabetes, despite that the diabetes are taken care of at home and managed at home. And you're saying that you can't manage them at your facility, but they're saying for whatever reason that due to the medical issues, right? So you would think a heart attack, seizures, any type of stroke, things like that would be legitimate reasons. But if it's anything medical that they don't feel like they can or want to, they can decline for that too. So facilities decline all the time for legitimate and sometimes questionable reasons, but there is no recourse for the designated crisis responder to say you will take them. The other thing for youth and adolescents, and we talked about this at the beginning, is that you can't detain somebody under the age of 13. So 13 is the cutoff. That's the magical age for a couple different things. That's the age of consent for treatment. That is also the age that a DCR can step in and do a evaluation for detention. Now, for those under, designated crisis responders can still help with family initiated. And that's a challenge because you're asking the family or legal guardian or any type of person involved with that to get some assistance, but have to do this stuff on their own. So that is another limitation. The other thing is here locally where I'm at, we have no local child adolescent units, and a couple of those are closing throughout the area as well. So having a facility that would even take specific populations, that also is true of our autism population. So anyone on the spectrum disorder or developmental disabilities, Alzheimer's, dementia units, there's very few, if any, specialized units that can take. So if the facility is saying, hey, this is organic brain disorder, this isn't a legitimate substance use problem, this isn't a diagnosable mental illness, this is dementia, it's an organic brain disorder. We're not equipped to be a dementia unit, we're not going to take them. As well as local detox facilities. Very few communities have access to a local detox unit, so they're having to send people elsewhere out of state. Last thing on limitations is that designated crisis responders can only detain for that initial 120 hours. So if the person needs additional care for stabilization after that, 120 hours is all they're going to get unless the court system and that facility recommends additional stay, which the next day would be 14 days. So if anybody's in the recovery community, how much does 14 days, 30 days, et cetera, really do for stabilization? You may need a lot more than that. So when it's only up to 120 of what I can guarantee you, it's really hard for somebody to stabilize with years of trauma, years of abuse. Even if they are sober, there's studies that say it takes 2 years for your brain to go back to some baseline, right? So 120 isn't much. So that's another limitation of detentions. All right, so going away from the boring part, away from ITA law, we're going to get into what a crisis truly is now. What a crisis is that is defined by the patient. It is self-defined. Okay. So if anybody tells you that is not a crisis, that is not true. If a person's telling you they're in crisis, they are in crisis. I don't care if it's because they couldn't find their favorite pair of shoes and now they're suicidal. It doesn't matter how silly, trivial to the person. If they are truly in crisis, it is. So again, it's a self-defined thing. So any intense, difficult, troubling, or dangerous situation, and they can be real, perceived, or not based in reality at all. Okay. So if I'm in crisis and it sounds silly to you that little blue men have tapped into my bank account and siphoned off money, they've put stuff into my skin, whether it is a perception or whether it's in reality at all, it does not change the fact that they're in crisis. So that is also where we want providers to know, case managers, peer work, recovery residents, that just because it doesn't meet ITA criteria does not mean your person is not in crisis. It doesn't mean they don't need some form of crisis services. So, but that is direct contradictory to how a designated crisis responder looks at this. So they determine that as a result of a mental disorder or substance use disorder, there is likelihood of danger to self, danger to others, or grave disability. Okay. So when we are talking on those terms, if we can take that self-defined crisis and put it into these terms that due to their drinking, due to their current state of mania, due to something that this is where it's leading, that's the best way that we can get some help from a designated crisis responder. But I do want to draw instance that does not mean that the person's not in any form of crisis, and we let them define that crisis. So assessment for any type of self-harm, suicide, homicide, when we are talking about diagnosis-wise, the most common imminent danger issues that are going to occur for anyone with depression, anxiety, or trauma are going to be symptoms of suicidal thoughts and behaviors, homicidal thoughts and behaviors, or non-suicidal self-injury. Now, when we're talking about for individuals who have been diagnosed with bipolar disorder, schizophrenia, or schizoaffective disorder, which has elements of both schizophrenia and bipolar disorder, are symptoms of mania and psychosis. So we're going to separate these out. We're going to talk about self-harm. We're going to talk about suicidal ideation. We're going to talk about mania, and we're going to talk about psychosis, because these are going to be the most common things that occur with this. And the reason why we brought up the polysubstance abuse, comorbidity, co-occurring disorders, is because these can all be substance use and induced as well. So you can have substance-induced psychosis, you can have substance-induced mania, depression, etc. Or it can be the fact that these are so together that we can't tease them out anyway. And it could be all of them. It could be the fact that they've been using stimulants for days, on top of that they haven't slept, on top of that they're depressed, so on and so on. So reasons for self-injury. Why we separate this out is because nobody likes their loved one to be self-harming, right? We have had parents that have wanted to fly over the desk because you're not detaining somebody who's actively cutting or actively burning themselves. And the reason for that is that if it is self-injury, we're going to go over some reasons why people, because it could be as simple as that it's a coping skill. It's not a positive coping skill. It's a negative coping skill. It's not actively adding additional value to their life, but it doesn't change the fact that it's a coping skill. Now, where that is, and it draws the line, is it on the neck, for example? Is it on an artery? Is it going up the arm? Is the self-harm in a spot that could result in imminent danger issues or death? Then yes, that's different. But if it's on the shoulder, if it's on the thigh, if it's on the calf, it's on someplace, visible or not visible, it may be that that is what they're having a coping skill. So when we talk about this, it is very important that if they're doing this, for example, to escape unbearable anguish, they don't know any better way. Now, we'll go through a bunch of these reasons. So again, negative coping skills, that change the behavior of others, to escape a situation, to show desperation to others, to get back at others, to gain relief from tension, to seek help. Any of these reasons why somebody could be self-harming, if you concentrate on the act itself without focusing on the reason why somebody is doing that, you are potentially taking the only coping skill that they have away. So for example, if I am cutting on myself and I'm doing it because I don't have any control in my life, and this is the only thing that makes me feel like I have some control, or I'm doing it because I'm numb and I don't feel anything. And when I do that, the pain pleasure principle activates, similar to good endorphins. That's why people in your books that you read or the Red Room like to be choked and spanked and pull their hair, because pain sometimes releases good endorphins too. We're all adults here. Okay. But pain pleasure principle. So sometimes I do feel something and I like that. It makes me feel something. I enjoy that. If you take that away now and they don't have that, then that's where the crisis can occur. So we don't want to focus on the act itself, the burning, the biting, the cutting. We want to focus on the reasons why they're doing that. And if we can supplement that with something that does the trick, that does give them control, that does make them feel something, that helps when they're numb, that's the focus that we want versus on this. So the bad thing that happens is that we take away sharps and we lock them all up. So now they can't cut at all. Well, if we haven't replaced that with something that does those tricks or helps them with that, we potentially took the only thing that's keeping them safe or well away. So how to help a person who is self-injuring? One is that we have to recognize that self-injury is usually a symptom of something that is a seriously psychological distress. Okay, so we have to recognize that that is a symptom of that. The other thing is to avoid any negative reactions to the self-injury. We don't want to go, ooh, ow, that looks like it hurts. Oh, and then draw a bunch of attention to it when that may be, and some people say, and this could be true too, is maybe that's why they're doing it, is to get some attention. And they haven't learned how to get attention in a positive way. So this is one of those ways. Okay. So we don't want to also reinforce negative reactions to that or draw attention to how that's mangled your arm, or what anybody else would say. Oh, you were so pretty, but now you did that, your skin. We don't want to focus on those type of things when we're helping somebody. The other one is that we need to discuss this in a calm manner. So if we are overreacting to that and we're drawing additional attention to stuff, we're not going to be addressing this issue on what is behind that self-harm. So we have to do this in a calm way and focus on ways to stop that distress from not cutting, to do something else. Some people do other things like it depends. This is a judgment call on rubber bands or using ice separate in this, right? Some people would say, well, that's better in the meantime, but that's not a long-term solution. But is it better than the alternative of using a sharp? Sure. So that is a judgment call on what you or your agency thinks and how to help with that. So there are some little things we can do in the ways to stop the distress while we work on the larger, more long-term issues on where that's coming from. Okay, so now probably what is way more important when we do this is what the do nots. So the other one is what we do not is focus on stopping the self-injury. And what I mean is that is the only focus. You don't just say, stop doing that. Don't do that anymore. And as long as you don't do that, you won't have any issues. That's like saying if you stay sober and don't use, you're not going to have any more problems. Well, if we don't address where the addiction came from and the reason why the addiction occurs, sobriety and abstinence isn't going to do the trick by itself. So just taking somebody's means of self-harm away and focusing on that isn't the thing that we want to do. The other thing is to trivialize somebody's feelings or situations about this. If they are telling you that I cut because nobody pays attention to me, don't laugh at that. Don't say everybody pays attention to you. Don't say your feelings or why. That's nothing. I had this happen. We all have one-uppers that say that's not a big deal. This is a big deal. So we don't trivialize anybody's situations. If they're telling you this is the reason why, that is the reason why. We need to take that as the issue, and that is what we help them with. Is that piece to that. The other one is punish the person. We don't say that I will withdraw care, I will withdraw affection, I will leave you, I will not let you come to group. I will do something as a negative thing to not, if they continue to self-harm, that there is going to be some punishment involved in that. Okay. So we don't punish the person for continued self-harm. We also don't put stipulations on that self-harm. The other one is to threaten that they'll lose their job, threaten that you'll break up with them, threaten to receive care. I'm not going to take you to the ED if you cut too much. These type of things don't really work for people. If the moral model truly 100% worked, if we did these things, people wouldn't have mental health issues. They wouldn't have substance use issues. It would just be the threat of incarceration, the threat of losing money. It would be the threat of these things that by itself just prevented people from doing that. So threats don't work 100%. They do have some benefit. There is some useful to more of the moral model, but at the same time, traditionally, these things don't work for everybody and they're not going to work 100%. So separating out now. When we talk about a risk assessment of suicide, we're going to break some things down individually on what you should perk up for. So one is gender and sexuality. If somebody is in the LGBTQ population, they are going to be more at risk statistically for suicidal ideation. The other thing is more of just your traditional, are they female or are they male? Reason why what they gravitate towards or what the gender assigned at birth is people say, well, why would one gender hurt themselves more? When you get into statistics, it's a little bit more complicated than that because it has to do with the means they use. Typically, females use less messy means, so pills for overdose. They will where men will jump off a cliff or drive their car at a high speed off of something into a wall or use a firearm. So the means that they use are more permanent from a male, and there's more time for a female who overdoses to call for help, to have that regulation of, and most studies show that anybody who has attempted to suicide, there is a moment of clarity that they truly don't want to die. They just wanted the pain to stop. So if I overdose, there is time for that. I can make a phone call. I can intervene. I can try to throw up. I can do some other stuff. Versus if I use a firearm, there's very little chance for error on that, depending on how you use that, to have that moment of clarity. And that's why, from an impulse standpoint, we want to take away the impulsiveness of this, make people have to go through several other steps to get to a firearm, anything of that. Now, even though we're talking about gender and sexuality, they're outliers. That doesn't mean anything. That is just statistically that in that bell curve, more people are in that than outliers. So there are females who will use a firearm. There are males who will overdose by pills. That doesn't mean anything. We just need to perk up on what is the means of use and what do they have access to. And it could lead that they're more likely to go one way or the other. So for age matters, and it matters on the spectrums. Are they very young and impulsive? And they've just been embarrassed. They've just been humiliated on social media. All of their chance of dating, they will never find another significant other. They'll never have a career. They'll never have any of these things. And when you're a youth, you're far more impulsive. So age does have an effect for those who are younger. It also, on the flip side of that, has everything to do with how old they are. It's on a rise that older white men are at risk of dying by suicide because as you age out, there are less people and less supports for you. Maybe you did have a family and maybe your family was very involved, but now they have children. Now they have their own traditions that they're using. So you see your family less. You see those people less. You did have social supports, but everybody else is retiring. They're off playing golf now, or they're unfortunately maybe passing away and they're dying. Your usefulness is at its up because you're retired. You don't have a job. You don't have a purpose. There are so many people who assign their purpose to their career or assign their purpose or their identity to what they do for a living. And so if they don't have that, then it makes them seem like they don't have hope. They don't have a purpose any longer. So at both of those, age-wise, very young people and older people are going to be at that risk level. But again, that doesn't mean that we don't, just because somebody's 25 or in their 30s, that we don't pay attention. So but those are just things to consider as far as safety levels. Chronic physical illness. So if somebody is, and this hits home because I've had this happen, is with I get a chronic disease or I hurt my back working. And if my quality of life is drastically impacted, and it hurts to get out of bed, it hurts to get in the shower, it hurts to sit, lay down, stand up, it doesn't matter what it does. If you ever hurt your neck and you're trying to drive and you're looking around, that sucks. If that was like your life all the time, you might be thinking about all means to make that go away. So anybody chronic illness or chronic physical problems, if their quality of life is impacted, they may be thinking about with the emphasis on how to make that pain stop. And sometimes people don't know any other way to make that pain stop, or there is a legitimate ways to make that pain stop. So suicide may be on the card. The other one is mental illness. So either treated or untreated. If somebody is diagnosed with depression, somebody is diagnosed with anxiety, any of these other symptoms that we're going to be tackling in this webinar, it may perk them up a little bit more on the issue because there's other things that come with that. There are some financial components that come with that. There are some supports that come with that. There are issues with obtaining employment. There are other issues that are obtained or complicated due to a mental illness that may perk that up. So again, that's to say that just because somebody has a good life, has means. We just had a Dallas Cowboy defensive end die by suicide. So again, we're talking about complications of this, but is it even diagnosed? Is it even there knowing? So mental illness on top of that can complicate those things, or a history of trauma. The other thing that pertains to this is use of alcohol or other substances. Are they actively under the influence? If they are under the influence, we may be more inclined to impulsive behaviors. We may make some choices that we wouldn't otherwise make if we were sober. So alcohol and drug use is going to be on there, and usually that's on any screen for that medical clearance. When we do bloody urine, is specifically for what potential alcohol or drugs are they on. Lack of social support. This is why those of us in the recovery community stress a lot for things like AA, NA. You want some additional support outside of education, outside of treatment, outside of your normal day. So lack of social support or loss of existing social support can make things very complicated for that. If I don't feel like anybody can help me or I don't have any additional outlets, that's going to complicate things. Sorry, I'm going to mute this while I blow my nose because I'm struggling. Probably should take it off camera too, but whatever. So the other thing is previous attempt. And usually when we have more of an active versus more of like a psychoeducational thing, when we're going for just presenting information, you ask people why a previous attempt matters. And you will get a bunch of different answers why it matters. But like anything in life, if I have tried something, whether that is an experience that I've never done before that makes me uncomfortable, if that is a new job, if that is applying for position school, if you have done something before, it becomes easier the more that you do it. So if somebody has previously attempted and they are still struggling with that, they have learned something from that. They learned what to do and what not to do. They learned who to call and who not to call. Right. So unfortunately, if you have had attempt, statistically, you are more likely to attempt again, but you probably learned something from that attempt to either one, like I said, I'm not going to call this person this time. I'm just going to not call anyone. I am learned from a past overdose, so I'm not going to do pills this time. I'm going to do something else. So we have to ask those questions on a previous attempt because it does matter on are they going to feel more comfortable or are they a little bit more at ease with that decision. The other presence that is organized plan. Do they have a plan? And that's where we talked about thoughts are thoughts. Everybody has probably had a suicidal thought, and I would struggle if somebody said, I've never had a suicidal thought in my life. Most people have and had a bunch of times. The difference is, do they put a organized plan together? So have they actually thought about it enough to, I know when I'm going to do it. I know how I'm going to do it. I've thought about the options and the risk versus reward. I've thought about all of these things to the point together that I've actually organized a plan. You are far more likely to go through with that in life if you put a plan together for anything. So that goes for attending school. You can't just show up and say, I'm going to go to school. You actually have to figure out, how do I do this? Do I look at what classes are available? Do I have to enroll? What is the enrollment criteria? Even though I'm enrolled now, what do I have to do? How do I fund this? How do I have to do? Same thing for getting a job. I have to know that someplace is hiring. So how do I do that? And then I have to put together a resume, or I have to put together a cover letter. I have to apply for the job, show up to the interview. Nothing gets done without putting some plan together. So if somebody's gone as far as putting a plan together on how they're going to die by suicide, that should really perk up on our crisis issue that we need to do something to intervene in this. So protective factors now. The opposite of hope is despair. And when you have despair, when you have depression, when you have little to no reasons for living, sometimes you forget the things that you do and the reasons why you should live. So protective factors, these are any reasons for living identified by the person. This is also goes back to the self-harm thing, but these shouldn't be trivialized. You shouldn't be making fun of people's reasons for living, even if it's to have plants in their garden, if it's to do puzzles, whatever the reason to live is, it's not to say that is your value system or that is your reason. So this is anything. So it can be trivial to you, it could be silly to you. It does not matter. It's theirs. So we want to get them to say, what are those protective factors? What is their reasons for living? So these could be religious beliefs. Some people feel like there is purgatory or hell that they would go to, or they have church involved. They have some spirituality, and spirituality can be anything different than organized religion. So anything of religious beliefs or spiritual beliefs that they have to keep them going. We also have beloved pets. Sometimes our pets, people like them better than their own children. Sometimes they are the only children they have. So any type of pet. So if they have a pet, we want them to understand that they want to be around for that pet, to care for that pet, to love that pet. Any family members or dependents, work and school. So other things that give people purpose or reasons for going. Positive therapeutic relationships. Maybe they have a great relationship with their peer. Maybe they have a great relationship with their therapist. And could they talk to their therapist after this? Do they have a med provider? Do they have a whole support system or a sponsor from AA? Do they have some type of therapeutic relationship that we could leverage and get them to talk with that? The other thing is social support. Okay, any teams, organized sports, any extracurricular activities. We talked about AA, NA, outside stuff. So, do they have social support that they can leverage? And then we have hobbies, collections, art, music, etc. It's fantasy football season. Do they have a fantasy football team, right? Get them to be talking about the things that they enjoy. Do they have they really like Christmas and there's a cool Christmas bazaar coming? Like whatever that is, do we have collections, hobbies, different music? Is there something that we can get them to think about giving an additional protective factor in there? If somebody has all of these, that is fantastic. Okay. Some people have little. So our goal from a treatment standpoint is to load up people's protective factors. We want them to have as many protective factors, have that Batman utility belt so that if they can have a thing for whatever that occurs, they have a protective factor for that. So we also have warning signs on the flip side of that. So where we have protective factors, we also have things that we need to worry about. Some of the obvious ones are threatening to hurt or kill each other or themselves and seeking access to needs. So if I'm trying to get additional medication or I'm buying a bunch of medication over the counter from stores or pharmacies, okay, if I'm looking for firearms and ammunition as well, if I'm seeking out means to do this, that should be a warning sign for us. Talking, writing about death, dying, or suicide. So if they write in their journal and they show you, they write poetry, they talk about it, they sing about it, they're listening to music about it, whatever that is, we want to perk up on those things. I'll go through this one because these are together usually feeling hopeless. So they have no purpose, they have nothing to live for, or they're feeling worthless that they don't matter to anybody or anyone. They have a lack of purpose. Acting reckless or engaging in risky behaviors. When I was doing therapy, I had individuals who this category falls into where they had protective factors being religion. They did not want to die by suicide because they feared that they could potentially go to hell. So what they were doing though is they were okay with other people doing that for them. So they would put themselves into risky situations. They would go down to a gang neighborhood and flip up rival gang sites, provoke gang members to attack them. They would do things to where they would have somebody else take their life. This is also where the death by police officer or death by cop comes from. So rather than doing it themselves, they'll engage in a risky activity. They will set this up to where somebody will do it for them because they don't want to do it. So any acts of being reckless, engaging in those risk-taking behaviors, we have to pay attention to those. Feeling trapped or increasing alcohol or drug use, whether that's due to a relapse or just increased use in general, using additional substances, using more of those substances. So whether it's more frequent, whether it's additional milligrams or dosage. And then the most common one that we know is like giving away objects, right? Prized possessions or withdrawing from family, friends, or from social things. So if you have somebody who is very active, they're attending their appointments and all of a sudden they stop attending or they withdraw from certain groups or activities, that's something that we want to check in on. We want to make sure that, hey, is it that you're sick? Is what's going on? Can I help? Is it a transportation issue? Or are they just seeing no point in that anymore? Or they don't want to engage in that anymore? And then demonstrations of rage, anger, or seeking revenge. If somebody feels like they've been wronged and they're really about the system, about individuals, about situations in life that they have no control of, if they are extremely angry, filled with rage, or seeking out revenge, that's something that we would need to pay attention to as well. All right. And then dramatic changes in mood. So this goes both ways, though. The one that we think about the most is if I was happy and now I'm really, really sad. I used to attend these things and now I don't attend them anymore. So I went from a positive to a negative. The one that we don't talk about is going from a negative to a positive. You were very depressed, and now all of a sudden you're super happy and you're super outgoing. What happens sometimes is that people have been struggling with this decision for a really long time. And for whatever reason, maybe they have their process in order now. They've given away their stuff. They have a will. They have a trust. They have something that they've done that they were feeling like was a burden that they've taken care of. They got a plot. They have a burial ground. They have something there, right? Or they have finally come to terms with they are going to do this, and there's a level of peace there, or a level of understanding or mood change. So drastic mood changes either way, going from positive to negative or negative to positive. We want to use those as times to intervene as well. All right, so questions to ask. How do we ask these questions? Because it seems like a heavy topic. How do you talk to somebody who's going through this? One of the things that we do is ask it as directly as possible. Okay. Sometimes we dance around the issue, or we ask it in a way that leads the answer. So we say things like, "You wouldn't do that, right? You wouldn't ever hurt yourself, would you?" When you ask it that way, you've already given them the correct response to be said, right? And the answer is, "You wouldn't do that, right?" Versus asking the person whether he or she is suicidal directly. So, are you having thoughts of suicide? There's no ifs, ands, or buts about that. Are you thinking about killing yourself? And unfortunately, I've had to do this both in work and outside of work to loved ones as well. And so, if you don't ask it direct, you open up things for interpretation. You open up things that you wouldn't do something silly, right? Or you wouldn't do anything permanent, would you? That's vague. What does that mean? So the more direct that you can answer that, the better. The next question is asking that person whether they have a plan. So have you decided how you are going to kill yourself? Have you decided when you're going to kill yourself? Have you started collecting objects to do that, right? Or material to do that, means to do that? Like, you want to ask the next piece of plan. Sometimes the issue may not be right now. And so if you're asking have to have a plan, the next question, like we said, is when would you do it? So for example, if I have an upcoming court date and I have somebody who I may lose custody of my kids, or I may not get Social Security or disability. There's something that's pending that I don't have yet, but I know because I work with this person that it's going to be 3 months out for that to determine. If that is the determining thing that they're struggling with, then we ask that question on when, because it's going to be a lot more prevalent when that decision is made in court. Did they go through their divorces finalized, and what is the kid arrangement? How much are they going to get? How much do they have to pay? These are type of things that you hear all the time. It depends on the court, depends on if I get charged, it depends on this. Okay. So when they would do it is a big thing. The other thing is, this was pertinent when I was working in jails, is if when you ask how and you ask when and you ask the plan, and if the plan doesn't apply to the situation, we have some time to put some other stuff together. So for example, this person in jail was saying that I'm going to jump out in front of traffic. Well, they were incarcerated for a long period of time. So if the bus isn't coming through here and they don't have means of jumping out in front of traffic, right, then we have some other time to explore. Are there other things that you're talking about? No, no overdose, no cutting, no access to other lethal means. It's only that. So it does give us also a baseline on what we need to worry about. Now, if they did say, I'm going to get hit by a car, I'm going to jump out in front of traffic, and we have to take them from point A to point B, or it involves being in a car, that's completely different, right? Now we're in a issue of like, how do we keep this person safe in transport? How do we keep them safe when we leave this facility? So it does play in, and you have to ask these questions because then we have a better understanding how to keep this person safe or away from any of the lethality of what we're talking about. And the other one that's kind of cut off is, have you collected the things that you need to carry out your plan? If they don't have that yet, we have time to intervene. So we want that person to be as safe as possible. And if we can reduce the chances of that impulsive behavior, this is why one of the things that we do for so many events is we give out lock boxes, and we ask people to store their firearms in a lock case or a safe, and we ask them to store their ammunition in something separate too. It's not that we're taking a stance on gun, but if I have to get that gun and I have to then figure out where the key is, how to get it, and then I have to do a separate measure to go find the ammunition, to find where the magazine's at, so on and so on, that I have to go through multiple steps. There's still a little bit more time to intervene in that if it's a little bit more complicated, or it takes a little bit more time to hit that, or have the thoughts that they want to change their mind or ask for help, or whatever that is. So these questions are important to ask. So how to talk with a person who is suicidal. So one is we want to let the person know that we are concerned and that we're willing to help. We have to state our intentions very clearly that I want to help you, I'm willing to help you, and I'm worried about what's going on. So we let them know that. Don't focus on anything other than the fact that you are trying to be supportive and you're concerned and you want to extend that help on what that is. Discuss your observations with the person. So what that means is you don't say, I'm worried about you, and leave it. You say things that are direct observation. You have missed our coffee dates 3 times in a row now. I'm worried about that. What's going on? So it's a direct thing. I noticed that you're pacing, you're walking up and down the street, and you're looking distressed. I'm pointing out specific things that I'm seeing versus just telling the person that you're worried about them. Then they have the ability to clarify. Maybe we're misinterpreting that and maybe it's something else, but at least if we direct observation, they'll know exactly what we're talking about versus taking it personal to them. We want to ask the question without dread. This may be hard, especially for people who have had multiple attempts and they've burned a lot of bridges, or we have dealt with this person and spent days, times, efforts, appointments, name it, on this person. So we don't want to say things like, "Oh, you're going to do it again. You're suicidal again. Are you going to kill yourself?" We don't want to say these things in a point to where the correct answer is to say no now because of the way you're asking it or your affect. We also don't want to express any negative judgments and appear confident when we're talking about this. Okay. You don't want to go to a mechanic who tells you that I don't know how to really do. We can throw some parts at this. Nobody wants to drop their car off. You don't want to go to a doctor who says, "I've never seen this before, but let's put you on a knife and do some exploring." Right. So if you don't feel confident, at least try to appear confident that you know what to do, so that person feels comfortable disclosing to you, and that you have their best interest in mind. We also want to check for 2 other things that we talked about too: is has the person been using alcohol or drugs, and has he or she made a past attempt? So how to talk with a person who is suicidal? One is that we have to listen non-judgmentally. And that is harder said than done because we live in an age where people judge everything. There's comments, both positive and negative, about everything. There's 2 sides to everything. So listening non-judgmentally has really gone by the wayside. And most people truly are just waiting for their turn to talk. They're just waiting for you to stop saying what you were saying so they could finish their thought and say what they had to say because it was far more important. So listening non-judgmentally is the key to that. We also want to make the person feel respected and accepted and understood. So that at least at the bare minimum, even with undesirable people or undesirable stances, even when working with sex offenders, with arsonist, with racist, we can still be accepting, genuine, and have some empathy for the situation, even if it's something that we disagree with or dislike or have a strong feeling towards. And then nonverbal skills. We want to be attentive, have comfortable eye contact, and use some open body posture. This is my default when I cross my arms when I'm talking to people, but that's not the best way to address this. I probably should be a little bit more open and understanding of what I'm doing, how I'm facing, where my legs are facing, how my face looks when I'm talking to this person. All right, so the other thing we want to do in addition to that immediate stuff is encourage appropriate professional help. So those are individuals like your doctors, psychiatrists, social workers, therapists, and any certified peer specialist. And then we want to, the types of professional help. So talk therapy is any type of counseling. We have psychopharmacology, which is med management, and then any other professional help and support. So we want to go through these things after we've immediately kind of figured out the safety level and what that next step will be. All right, so moving on to mania. So mania can be induced via drug, it can be induced via lack of sleep, or it could be the fact that the person has bipolar 1 disorder. So When we talk about mania, it's a distinct period of abnormally or persistently elevated, expansive, or irritable mood and abnormally and persistently increased goal-directed activity or energy. On the surface, that sounds great. If you can harness that and you don't have any negative symptoms of that, that's awesome. That's why people who potentially on a strength-based approach have this diagnosis can be really creative. They can be really successful. If you can harness that for good, that can be a huge strength. So when we talk about this, though, symptoms must at least be for 1 week and be present most of the day, nearly every day, in any duration of hospitalization if is necessary. So the mood disturbance element of this is severe enough that it's caused by marked impairment in social and occupational functioning, or it necessitates hospitalization to prevent harm to self or others. So again, if this person has and lives with this diagnosis, but they maintain their sleep, they maintain a good appetite, they have support systems, they avoid drugs and alcohol, they can harness that for a lot of good. So more stuff on there. So when we talk about, because everybody would say, well, I feel at times I have a lot of energy. I feel like I have a lot of goal-directed activities. So we're going to break some of this down a little bit more. So whether they have an elevated or expansive mood, so excessive cheerfulness, not just that they're feeling good, that they have that euphoria, they have a feeling of intense high. They're usually optimistic, upbeat, and even in challenging circumstances, it doesn't bother them. They're trucking through. May seem overly intrusive in social interactions or friendly. On the irritable mood side, they're easily frustrated or agitated, quick to anger. They often present when desires are thwarted or when they're experiencing racing thoughts. A noticeable increase in goal-directed activities, so for work, social, or sexual. So they can be sometimes religiously preoccupied, sexually preoccupied, to the point where it is inappropriate. And then restlessness, fidgety, pacing, etc., or taking on new or a lot of simultaneously activities. So they have uh, maybe to the level that they can't actually even keep up with it, but they still think that they can. All right, so prominent issues when somebody is in a manic episode or they have media-induced symptoms, there's a decreased need for sleep. So they start that they 2 to 3 hours or no sleep at all. They feel like they can go through that. Racing thoughts and ideas. So the thoughts are moving very quickly from one to another, and they have difficulty concentrating on a task. And so their mind is going too fast. They also have pressured speech. One of the things that we look at in a mental status exam is their speech. So is it of normal rate, rhythm, and tone, or is it rapid? It's loud, it's uninterrupted. There's no gaps between sentences or commas in there. They're just keep going. And then distractibility. So they have difficulty staying focused and on task. You're trying to evaluate them and they're talking about something else, or they're on to the thing looking at somebody else. They're trying to change the topic. So other than prominent manic symptoms, grandiosity. So this can be that they think that they're not just that they're a good painter, but that they're going to be do the next Mona Lisa. They are going to be famous. I've seen this with music a lot, that they just need to meet this one person and they have a plan to go meet them at their concert. They're going to give them their demo. They're going to be the next Taylor Swift, right? There's impulsivity or risk-taking behavior attached to that. So examples of that is going to be reckless spending or unprotected and many sexual encounters, foolish business investments. They're going to develop, not only are they going to invest in crypto, but they're going to make their own crypto, right? They're going to have their own coin. There's gambling, substance abuse, poor judgment in there. And mania can have some psychotic features. So there could be delusions or fixed delusions. They can feel like they have superpowers. There could be some elements of uh, where they have command hallucinations that tell them to do things. So they're hearing voices that say, if you don't do this, A, B, and C negative will happen. So moving on to, because mania can have, and so can depression too, is we're going to talk about some psychosis. So typical diagnoses that can have psychosis involved is schizophrenia, bipolar disorder, schizoaffective disorder, and drug-induced psychosis. So when we talk about psychosis, what does that mean? Well, psychosis is a condition in which a person has lost some contact with reality, and that person may have severe disturbances in their thinking, their emotions, and their behavior. So This usually occurs, and when we talked about the malingering element of that, this is not constant, uh, but it usually occurs in episodes, meaning that it's not intense all the time. It waves and flows, but you don't get to turn it off like a light switch. So it doesn't stay intense. The voices may be really loud, they may be really intense, and they go away, but they don't go away completely. They just may be manageable at that point. So if somebody's telling you that you just do this and I won't hear voices, that's not really how it works. You don't get to control and turn it off as constant. It's a static condition, right? So more on this, a couple different things to pay attention to is when somebody is losing touch with reality and they have hallucinations or delusions. There is a difference between delusions and hallucinations, and it's very helpful to know the difference. So easiest way to say this is if I have a delusion that I am Jesus, that is a delusion. I am saying that I am somebody that I am not. If I hear Jesus, see Jesus, that is a hallucination. Jesus talks to me. Okay. So delusions versus hallucination, what is I am that versus I experience that. There's also illusions sometimes that people think are hallucinations. For example, we had somebody from the recovery residence call us and said that my resident was seeing spiders on the ceiling. And so they're hallucinating. And you venture into that a little bit more, and they turn the light on, and it's the way the popcorn ceiling looks. Then it looks like they're spiders. And then you turn the light off again, and it looks like they're there again. But you turn the light on, it's popcorn ceiling. So illusions are things that we see that we think are something else, but like for example, I would come out at 3 in the morning, turn on the back porch, and I see somebody there. Well, when I flip the light off again, or I flip the light on, I can see that it's really the trees and shadows. So I saw something that was really something else. That's an illusion, separate than a hallucination. If the see spiders on the ceiling, whether I turn the light on or off, those spiders are still going to be there. So there are a couple different ones. Auditory is our hearing, visual is seeing, tactile is our touching. So for people say that they have stuff crawling on them, and olfactory, so smelling, and gustatory is tasting. So a couple different ways for this that are important too is if somebody is telling you they have auditory and visual hallucinations, those are the two most common for people who have organic schizophrenia or schizoaffective disorder, where tactile hallucinations are going to be probably more likely that you've experienced some drug use. That being the most common one. If they have olfactory and gustatory, that's usually a result of a head injury, and it can be that we need to get this person checked out for maybe they have a traumatic brain injury or they had a concussion. All right, so symptoms when psychosis is developing. So we have some changes in their thinking. There's some changes in their perception. So they may talk about unusual ways of describing things too, like they taste sounds, they hear colors. There could be other odd ideas in there. There may be some changes in their sleep disturbances, some social isolation or withdrawal. One of the things about psychosis that you hear is that they're dangerous, but people who experience these symptoms and have the diagnosis of schizophrenia are typically victimized way more often statistically than they are victimizers. So it may scare people, it may alarm people, especially when it occurs in the community and they're yelling, but they're just yelling at the changes in their thinking, their perception. They're typically yelling at the voices versus yelling at others. All right, so common symptoms where psychosis is developing, there could be all these type of things. Uh-oh. Did you lose that? Can you still see screen?
We see the
Uh-oh.
camping screen, so the slideshow's gone.
Okay,
Looks like, yeah.
I don't know how that happened. It just went away. I'll bring it back up though.
Maybe it was a part.
Can you see it again now?
Yes.
Okay.
Yeah.
Get through all of it. Yeah, it seems like a lot when you're almost towards the end. All right, getting back to this. So one of the things that we look at with symptoms of psychosis is a lot of times people are trying to communicate, but they're having difficulty communicating. So one of the things that is cool for people that experiences those simulators, that experience what it's like to actively try to hear voices, try to focus on somebody talking to them, and all of the things that are coming in and out of stimulus in my head. So that usually manifests in some form of a blunt or a flat affect, not responding appropriate to mood or emotion or current room or vibe of the facility or whatever's going on, and they're filtering out a lot of stimuli. So what happens is that typically results in a some type of response latency. So you ask them a question, and time will pass before that person is able to answer that question. So you're asking, "What's your name?" and seconds go by. And so you decide, okay, well, that take too long. I'm going to skip it. Where do you live? And then time goes by, and you're on your third question. They're starting to answer the first. So there's a response latency that goes by because they're filtering out all of those things in their head, trying to answer your question and pay attention as well. So response latency is something that we see all the time. So why do we want to try to intervene as early as possible? Some people will say, well, why do we care about early intervention? Well, you care about early intervention because, especially if it comes to any of these things, let alone mania and psychosis, is there are studies that show when you end up in a manic episode or you have a psychotic episode, you're doing damage to your brain. So your baseline level of functioning is dropping. And if you do permanent damage to your brain, it is hard to regain that or go back to a baseline prior to that. So poorer long-term functioning occurs. And when you have poorer long-term functioning occurs, it's more likely that you're going to have ongoing issues with depression or suicide. You're going to have, for example, those of us who have family members who used alcohol or drugs at an early age, they did damage to their brain. They're lower at a maturation level, right? I have a cousin who, even though he's a 50-year-old man, it's like talking to a 16-year-old. There isn't going to be that functioning level that you think that chronologically they should be at. But due to the damage they did, they're going to be stuck at that. There's also other strains on their support system or their relationships. They may have trouble finding a job. They may have their alcohol or drug increase, loss of any type of competence, or issues with the criminal justice system. So how to help with mania? It looks like we're getting up to this, so I'm going to speed a little bit more through to these so we can get to any questions. So with mania, we want to, similar to the other ones, is to approach these in a calm way. If somebody is very grandiose, very energetic, we don't want to match their state. We want to calm ourselves so that hopefully when they do mirror us or they understand that they're talking way faster than we are, that we can mimic some of that. We also want to do this in privacy. We don't want to pull the person in front of a bunch of room if we can get them to a place where they can feel like they're not with other stimuli or they're not getting talked to by other people or have other distractions. If we get them to a place of privacy and confidentiality, we can talk to them a little bit better. So initial approach to some of this de-escalation, we always want to stay calm, establish a safe environment. We want to communicate very clearly and concisely. So that means using simple, direct language, speaking in calm tones. What happens to us too when we get into this from a clinical standpoint is we start to use clinical jargon or complex explanations. We want to say things that talking to a normal person who doesn't have a clinical background, whatever normal means, right, but doesn't have that same background, that they would understand the terms we're using. And then listen effectively and actively. So if somebody is having racing thoughts or disorganized, try to understand them for what they are, is that they're just symptoms, because this frustrates people. They get upset. You're not paying attention. Then they start going, they start escalating the situation versus the person isn't doing it on purpose to you. They are experiencing something, right? We also need to validate the feelings, but this is something that when we are talking about people who may be experiencing mania or psychosis, we never agree and we never disagree with delusions or hallucinations. You never say that's not happening, that doesn't exist, or you're not saying, yes, I see them too, if you don't actually see them. If you do that, they're going to think you're in on it, or they're going to think you see it too. And eventually they're going to figure out that you probably are lying. You'll lose that rapport. We also don't say that's not true because then we put ourselves at odds that either we're in on it and we're just denying it, or they're a liar, or whatever that is. So the easiest thing to do is just say, that sounds very scary, and I believe that you believe that, but I don't, or I don't see it. So acknowledging that they are experiencing it, but you don't, is okay without saying you're lying or yes, I do, and I can see it too. We also need to set very clear boundaries on when we can address things and how we can address them. So the thing we do is provide some practical support, help reduce that stimuli like we talked about, get them into a place that isn't very loud, that doesn't have a TV on, that doesn't have a radio going, some place that we can monitor if they have risky behaviors, that they're not going to have access to a cash register or things to spend on. We're not taking them to a mall or someplace to talk where they can spend a bunch of money or see a bunch of people. Or so we have to think about it from an element of, are we adding to their stimuli or are we helping reduce that amount of stress? I'm thinking what we need to do is find trusted individuals. So if we are not that trusted individual, but they do have a peer that works for a different agency, or they have a case manager, or they have a cousin, sometimes it's not going to be us. And this is hard for parents to hear too. But if you're not that trusted person or that trusted adult, that's okay. We're going to help find you that person or get you access to that. We have safety plans, know the resources in our community, and know when to call for help, know when to call 988 or a local cost, know when to call 911. All right, so how to talk to somebody who is actively in a psychotic episode. One is that we need to speak slow and clear. And for somebody who talks fast like me, this is painful to do because you have to talk in an extremely slow way so that they can filter that out. We also want to show hands. Don't keep them in places that we're in your hoodie, in your pockets. And if we are giving directions, we only give one direction at a time. We don't say, get up, get your stuff. We got to get in the car. We got 15 minutes. You just say, can I get you to get up off the bed? And until they get up off the bed, you don't give the next direction. We give only one command or one direction at a time. And as we talked about this, we don't disagree or agree with delusions or hallucinations. And again, don't give a bunch of long descriptions on what's going to happen or what you're going to do. All right, I'm going to get to questions because I almost hit right with a minute left. So I wanted to allow some time for any questions if you have them. All right, I see nothing in the chat. If you want to come off mute, you can. Oh, I did see something. Is this different from Ricky's Law? Yes, Ricky's Law was for substance abuse to help people, but prior to 2018, the law changed where we included substance use disorders in the ITA criteria so that we can detain under substance use disorders just under the regular Involuntary Treatment Act. And Joel's Law is different because that is if you can do it for both. If there is somebody who got evaluated, didn't get the desired result that you think they should have, or we couldn't find them, then you can use Joel's Law for that. All right. All right, Brianna, that brings us to 11:30.
Wonderful. Thank you so much. All right, so I will send the slides and the video recording. It will also be available on our WAQRR YouTube page as well, in case you want to share it with anybody else. If you have any questions, feel free to just send me an email and I can always pass them over to Cameron if some come up later. But everyone have a great rest of your afternoon, and thank you so much for coming. And thank you,
Thank you.
Cameron. It's
You're
really
welcome. Thank you. Bye.
bye.